afternoon, everyone. My name is Ross Wallace. I'm an advisor to the Resilient Healthcare Coalition and a principal at Santis Health. It's my great pleasure to welcome all of you today to an RHC and PHSSR webinar on connecting the dots, why better chronic disease management leads to more resilient healthcare systems. We have a fantastic and jammed hour of presentations, responses, and discussion ahead of us. But I'll just take one moment to let a few more folks join us from the virtual reading room, and then we'll kick off today's discussion. So bear with me, and we'll be back to you in one moment. Okay, as I watch our numbers continue to climb, let's kick things off and respect the time that you've given us today. So very excited about the opportunity to have a very important conversation about resilient healthcare systems and about non-communicable diseases today. Let me just take a moment to talk about the Resilient Healthcare Coalition itself. The RHC is a collaborative of health system partners who are collectively committed to providing leadership, insights, and solutions to make healthcare systems across Canada stronger and more resilient. Our steering committee encompasses a diverse group of more than 20 health system leaders from industry, from the research community, and the patient groups across the not-for-profit and private sectors. Our mission is to create Canadian healthcare systems that improve patient care and health outcomes through three fundamental goals: optimizing the use of healthcare data to better inform healthcare decisions, expanding and accelerating patient access to innovative health technologies, and strengthening Canada's life sciences sector. One of the most important voices that the RHC has been listening to since our inception is the Partnership for Health System Sustainability and Resilience, or the PHSSR. The PHSSR has just released a new report focused specifically on Canada entitled Policy Roadmaps for Acting Early on Non-Communicable Diseases. We couldn't be happier to convene today's conversation on that report, its findings, and its implications for policymakers and health system leaders across Canada. Our discussion today will be anchored by the report's lead author, Dr. Sarah Allen, who's an associate professor of health policy at the Institute for Health Policy, Management and Evaluation at the University of Toronto. She'll have a more fulsome introduction in a moment, but following her remarks, we're going to have three respondents commentating on the report, its insights, its implications, and its findings. First, we'll have Dr. Jason Field, who's president and CEO of Life Sciences Ontario, and also a co-chair of the RHC. Then Kim Hansen, the Chief External Relations Officer at Breakthrough T1D. And finally, Dr. Nakashi Lamptey, Deputy Chief, Medical and Scientific Support, Population Health at Public Health Ontario. So let me just take one moment to let you know about kind of the housekeeping aspects of this discussion. As you will see at the bottom of your screen, either sort of as a freestanding icon or in the More button, if you click through to that More button with three dots in a circle, you'll see a Q&A button. That Q&A button allows you at any time over the course of this conversation to share your thoughts, your perspectives, your commentary, and the questions you'd like the panelists to talk about today. So we encourage you to use that Q&A button as early and as often as you can, and we will attempt to answer as many questions as possible over the course of the conversation. With that, it's my great pleasure to introduce our introductory speaker, who's going to offer some context on PHSSR, on the report, and on Sarah Allen herself. So to you, Kim Loria, who's the head health system strategy at AstraZeneca Canada. Thanks, Kim.
Thank you so much, Ross. Good afternoon, and thank you for joining us for what promises to be an engaging conversation. As Ross said, I'm Kim Loria, Head of Health Systems Strategy at AstraZeneca Canada, and it's my pleasure to welcome you to today's launch of PHSSR Policy Roadmaps, Acting Early on Non-Communicable Disease in Canada. The report is available on the PHSSR website, and there will be a French version to follow shortly. I'd like to start with a special thanks to the Resilient Healthcare Coalition for bringing today's webinar to life and acknowledge the efforts of the broader Partnership for Health System Sustainability and Resilience, which is comprised of local and global reaching organizations, including Philips Canada. AstraZeneca is honored to be a part of these organizations whose rigorous research makes this report possible. This collaboration represents exactly the kind of partnership needed to drive real transformation. Let me set the context for today's discussion. The coalition brings together health system leaders from industry, research, and advocacy. Their mission is to create healthcare systems that are nimble and able to absorb shocks like the pandemic. Uniting diverse stakeholders, they focus on two goals: optimizing healthcare data to inform better decisions and expanding patient access to innovative health solutions. PHSSR complements this vision perfectly. It is a global research partnership that brings together academia, industry, and policy leaders, with work conducted in more than 30 countries to generate comparative insights and practical policy recommendations for health system performance and resilience. So why chronic disease management and why now? Canada lacks a national integrated chronic disease framework, leaving prevention, early detection, and management uncoordinated for conditions that are driving most deaths, avoidable hospitalizations, and spending. This results in a reactive system, fragmented data, weak population health planning, and prevention that doesn't scale, undermining resilience and value while deepening inequities for Indigenous peoples, rural communities, and lower-income Canadians. Today's insights and ready-to-implement recommendations can transform chronic disease care in Canada. Now we must turn data insights into action, and we need your help to move the needle. AstraZeneca is committed to working alongside governments, health system partners, patient organizations, and industry colleagues to drive the meaningful system-wide change that Canadians deserve. I'm pleased to introduce our next speaker, one of the report authors, Dr. Sarah Allen, who is an associate professor of health policy at the Dalla Lana School of Public Health, who will dive deeper into the report to clarify the scope of what we're facing. Dr. Allen, over to you.
Thanks so much for the intro and opportunity to share today in a very short and engaging presentation some of our findings from our report that's available for all of you to read afterwards. So it's wonderful to have a chance to be on this panel, and I look forward to hearing from my colleagues and others who have questions today. So I'll just kick off with an overview of like why we know why this is important, but just a few stats to sort of situate this presentation, which will provide an overview of some of our key findings from the report that, as was introduced, the Partnership for Health Systems Sustainability and Resilience, which is led by London School of Economics and Political Science and includes many of the partners named. So this report is the first in the series that covers 8 OECD countries. But globally, this is a major issue. As we know, 18 million people are estimated to die prematurely from non-communicable diseases each year. Collectively, the sort of 4 categories of non-communicable diseases that this report focuses on make up over 80% of the global burden of disease. And many of these non-communicable diseases develop over time, and a substantial share of the burden is preventable, often reflecting the broader conditions that people live and work and age and the treatment options available to them. And we have a window to act early through prevention, through improved risk identification, improved screening, timely diagnosis, and robust chronic disease management. And this is the sort of thrust of an aim of this report. And the report really leverages an evidence-based framework that was developed by our colleagues at the London School of Economics. The framework is comprised of 7 overarching domains, and these are, listed here on this slide. I don't need to read them, but they were developed with a sort of assessment framework that then used, and we conducted literature reviews. We supplemented that with a survey of experts across Canada, as well as local consultations with system leaders across the country. And, these also received feedback from international experts as well. So the broad aim of the report is to strengthen Canada's health system's capacity to prevent, respond to, and treat non-communicable diseases. And we try and uncover some of the key challenges and outline some recommendations for action. But today, I won't go through every domain, but rather I'll focus on providing a bit of an overview of non-communicable diseases and population health in Canada, and outline some of the major kind of cross-cutting themes that came out from this report, focusing on data fragmentation, access gaps, and system prioritization. And we hope that this will be a good starting point to kick off some discussion together. So overall, this slide presents some of the data that we include in the report. And notably, Canada is a middling performer when it comes to managing and preventing non-communicable diseases. Across the OECD, age-adjusted, disability-adjusted life years, this is the figure that you see on this slide, there's a downward trend, which is a promising indicator of improvement. However, over time, because of population aging, more people are living to ages where cumulative lifetime exposures increase the prevalence of chronic diseases and place more pressures on health systems. So we see the total unadjusted disability adjusted life years increase over time. And we notably, cancer and heart disease are two of the conditions that we cover in this report, and they account for about 44% of all deaths in Canada. But we know multimorbidity and complexity is increasing over time. Estimates are now putting about almost half of adults with some multimorbidity with the latest available data. And inequalities are persistent over time. To the extent that we can measure them, we see inequalities in health and in access to care throughout all of these disease categories. The health system impacts of non-communicable diseases are challenging to really put, to really estimate with data, but this is one indicator of the impacts of non-communicable diseases, looking at one specific subgroup of diseases, which is for COPD and asthma. And when we look at the hospitalizations for these conditions, we see that in Canada, while there's been some decrease, which we want to try and prevent hospitalizations for these conditions as much as possible, there's been some improvements, but Canada's rates of hospitalizations are still above the OECD average. This suggests there's room for improvement to better manage and prevent these more high cost later stage presentations through better chronic disease management and prevention. So when we talk about data fragmentation, we know that Canada's decentralized health system would lend itself necessarily to some fragmentation, but the extent of the data fragmentation in Canada is significant. So we know that there are multiple data sources available to really understand the burden of disease, but also to measure quality of care and so on. But these are mostly existing in silos. We know that there have been some federal attention to this area with an expert advisory group on health data. And from that 2022 report, they really emphasized the substantive and long-standing gaps with systemic data fragmentation and outdated data sharing policies. And these were key findings in our report as well. Indicators are not consistent across jurisdictions, so we cannot readily compare the prevalence of non-communicable diseases in a consistent way. We can't compare multimorbidity or screening uptake or access to care consistently across the country either. And this fragmentation also limits sort of the ability of our data systems to communicate with each other or be interoperable. It's difficult to track patient pathways or monitor outcomes of care across settings. Equity measurement is constrained as well. We are inconsistent and inadequate in our disaggregation and the ability to kind of disaggregate data across social indicators. So a key takeaway from this is that we need to really continue to emphasize and enhance data collection, indicator development that can be used to support national and provincial territorial strategies and to monitor their impacts over time. Just as an example of this challenge of data fragmentation that we highlight in our report is the availability of disease-based registries. So we have some fairly good registries for some diseases, mostly with regard to cancer registries that are quite well covered both nationally and at the provincial territorial level. But mostly we're missing these robust data sets that would allow for the type of monitoring, measurement of care and tracking improvements over time. There are major gaps in disease-specific registries across Canada. And interestingly, sort of the broad chronic disease registry approach is only seen in few provinces, such as Newfoundland and Labrador, British Columbia, and Quebec, as an example. Data is a major problem that we know in Canada that impacts our ability to act early on non-communicable diseases, but access gaps are a pressing concern as well. Primary care is really where the sort of foundation of non-communicable diseases prevention and management lies, and is the entry point to the health system. We know there's a major problem in Canada with inability to access primary care and just having a regular place to go, with estimates suggesting about 6.5 million Canadians, and that was back in 2022. More than 1 in 5 adults are estimated to lack a primary care provider. Access is uneven across rural and urban areas, across social determinants, with lower income households less likely to have access to a primary care provider. And even when the patients have access to primary care, there are significant barriers receiving timely diagnosis and referral. In 2020, Canada had among the longest wait times for specialty care among Commonwealth countries. And 62% of survey respondents in 2020 from the Commonwealth Fund survey reported waiting over a month for access to specialist care. And we know that specialist appointments really do delay non-communicable diseases detection and treatments. We have major workforce shortages and distribution challenges across urban and rural areas. And, overall, we see consistent evidence of these access gaps that really support a priority of improving equitable access to integrated and accountable primary care teams, and optimizing skill mix and expanding virtual and mobile care. Primary care teams, which could include physicians, nurses, pharmacists, and allied professions, are known to improve the management of chronic conditions, but access to such teams is quite limited in Canada. And so we also have many examples of the kind of innovation in virtual and mobile care use, but these are far from being the main approach or available to most Canadians. Just by way of an example, we know there are many access gaps and ways to measure this. And this is just a striking example of one particular area of a challenge in Canada, which is around cost barriers to medications specifically, which in Canada, other than the United States, it has among the highest challenges with cost-related non-adherence. This is challenges to just being able to afford their medications in Canada, which is higher than in other countries. This one survey data is from the Commonwealth Fund International Health Policy Survey of older adults, where we would expect these rates to be much lower, but it's still about 6% of older adults report these cost barriers to medications. And they vary across the provinces, with much lower rates in Quebec, for example, than in Ontario, New Brunswick, Newfoundland, and BC. We also really focused on the ways in which provinces and territories and the federal government really prioritize non-communicable diseases. And we found wide variability in the sort of evidence of prioritization. And, there are some national strategies for cancer, for example, few national strategies for others, with chronic respiratory diseases, stroke, and other high burden non-communicable diseases have little attention been paid to them. We know that there are some guidelines available, and organizations like the Canadian Task Force on Preventive Healthcare has developed some evidence-based guidelines. These are not, we don't monitor the extent to which they're adopted across the country, and most of these guidelines are not up to date. And there's variability across the country in terms of the approaches taken to monitor and sustain healthcare quality in Canada. So we suggest from this review that the development of disease-based strategies can help to strengthen accountability for measurable outcomes with regard to improving non-communicable disease management. These strategies can include, the statement of a clear objective with measurable targets, ways to monitor them, and to assess gaps and evaluate whether these strategies are working. And focusing on diseases that have high burden would be an appropriate place to start. And this is really a room for improvement in the country that we find is a unique challenge in Canada. So just to wrap up and to sort of open up for discussion, we argue in this report that Canada's health system could be a top performer. There is considerable room to improve our ranking internationally. And by reducing the burden of chronic disease, we need to work together. So this research hopefully can inform the type of alignment of priorities and address some of these persistent challenges in our data systems and our access, and overall improve outcomes and reduce the burden of non-communicable diseases in Canada. And we really hope this report will be useful. The Canadian report is available here. There's also a summary report available online that speaks to some of the cross-cutting findings across countries, and these are available on the website. So I look forward to hearing the panelists' discussion and Q&A. So thanks very much.
Sarah, thank you so much, not only for attempting to take a very detailed, comprehensive, and data-filled report and turn it into 8 slides, which you did in a super magisterial way. So we appreciate the foundational kind of cornerstones you've given to this conversation to come. And frankly, for many years of diligent, impressive, and important work that you and the team have conducted to get to the point that this report is being released and everything that happened before it. So thanks for being here, and thanks for kicking us off. So I'm going to open up with our first respondent, Dr. Jason Field, who's the president and CEO of Life Sciences Ontario and a co-chair of RHC. So Jason, to you.
Well, thanks, Ross, and special thanks to RHC and PHSSR for convening this session today. What I think is most important about this conversation is that it does connect chronic disease to something bigger, which is health system resilience. And I think that's exactly the right framing. If we want a healthcare system that is more sustainable, more equitable, and more responsive, then we have to get much better at preventing chronic disease earlier by detecting it earlier and managing it better over time. And as the presentation highlighted, that means addressing the 3 linked challenges that Dr. Allen highlighted, the data fragmentation, access gaps, and system prioritization. Certainly, the report clearly shows that chronic disease, it's not a niche issue in Canada's system, but rather it's central to our system's future. In 2023, 46.1% of Canadian adults reported at least one chronic condition. And the report's core point is that early action on chronic conditions is not just a clinical issue, it's a system design issue, with implications for equity, performance, and long-term sustainability. That framing aligns very closely with work that we published at Life Science Ontario last year in a report titled Going Upstream. Our starting point was simple. Ontario is still trying to manage a modern chronic disease burden with a system that's largely built for acute care back in the 1960s. And that mismatch is now one of the defining pressures on the system. Our key message was that we need to move upstream, not just in rhetoric, but in how we actually organize care. We framed that around 3 pillars, which was prevent, mitigate, and manage. That is very much in step with this current report's call for earlier intervention across the continuum. Before complications escalate, before costs rise, before patients end up cycling through a system that is still very much reactive. Where we at LSO kind of added a practical Ontario lens is in saying, let's start this process with a focus on diabetes. And we chose diabetes because it's both highly prevalent and highly consequential. It's a gateway condition, one that can lead to heart disease, stroke, kidney failure, amputations, and blindness. So if we improve prevention, screening, and management for diabetes, we're not just solving one problem, we're actually building a platform for better chronic disease management more broadly. And so the urgency is real around this. As our report pointed out, 1.7 million Ontarians were living with diabetes in 2024, and that was projected to rise to 2.3 million by 2034. So this is not an issue that we can, a can that we can kick down the road, so to speak. It's a current system issue and one that is continuing to grow rapidly. On the data fragmentation piece, there's also very clear alignment between PHSSR and our report. This current presentation calls for stronger pan-Canadian measurement standards, better collaboration through CIHI so we can establish more standardized chronic disease indicators across jurisdictions. LSView is similar at the provincial level. Ontario needs modernized chronic disease data systems that track outcomes, evaluate interventions, support planning, and enable regular public reporting. Because if we can't measure chronic disease properly, we can't manage it strategically. And once again, we're just left reacting after the fact. On the access gaps, again, there's strong alignment. PHSSR points to uneven primary care access, inconsistent screening uptake, long waits, outdated diagnostic infrastructure, and limited implementation of integrated care pathways. LSO translates that into practical actions for Ontario. Expand screening through pharmacies and community-based services, strengthen diabetes education and culturally relevant prevention programs, integrate mental health supports, and make fuller use of allied health professionals and remote care models. Those are the kinds of interventions that close gaps earlier and, importantly, more equitably. On the system prioritization, I think both reports are really saying the same thing. Chronic disease cannot remain an issue that is everybody's concern, but nobody's operational priority. PHSSR notes that Canada has only a few national strategies for major non-communicable diseases, with important gaps for many high-burden conditions that registries and accountability mechanisms remain sparse as well. LSO's position is that Ontario needs clearer leadership, clearer accountability, and care pathways designed for chronic illness, not just episodic acute intervention. So in Ontario, there was Motion 45, and it really mattered because it signaled that Ontario should develop a provincial framework for chronic disease, starting with diabetes. But as we said in our report, progress has really stalled. So the opportunity facing us now is to turn that signal into implementation. From a life sciences perspective, there's an important enabling point here. Innovation is not only about new medicines, though those are essential. It is also about diagnostics, digital tools, remote monitoring, better data infrastructure, and better care pathways. PHSSR explicitly identifies the role of medicines, technology, and digital health in improving chronic disease management, while our report points to innovation and remote care tools to extend access and improve continuity of care across geography. So in closing, if we want a more resilient healthcare system, we need to address chronic disease. We need to act earlier, organize better, measure better, and build models of care around the realities patients are actually living with. PHSSR has provided a strong national roadmap. I think our contribution is to say, let's make that real in Ontario, starting with diabetes and building outward from there. Because better chronic disease management should not be seen as a downstream cost. It needs to be viewed as an upstream investment in health system resilience. Thank you.
Jason, thanks so much for that perfect build on Sarah's remarks, and a lovely segue to our next speaker, who's going to go much deeper into a number of things that you raised, including the importance of delivering comprehensive, thoughtful, and integrated care for diabetes. So to you, Kim Hansen, Chief External Relations Officer of Breakthrough T1D Canada.
Thank you, Ross. I'm speaking today wearing a few hats. As someone who, while I worked at Diabetes Canada, helped to lead the development of the framework for diabetes in Canada, as a patient advocate, someone that lives with type 1 diabetes, and as someone who now works every day at Breakthrough T1D, the leading global type 1 diabetes research and advocacy organization, working every day to make every day better for those living with the disease while driving toward cures. What I really appreciate about the PHSSR report is that it doesn't just diagnose what's wrong, it challenges us to imagine what a more resilient health system could actually look like if we act deliberately and earlier on chronic disease. For diabetes, Canada has actually taken an important step forward. With the framework for diabetes in Canada, we now have a nationally endorsed framework that sets common direction across prevention, care, research, data, access, and equity. That matters for resilience. Systems that are not aligned around their highest burden chronic diseases cannot adapt well under pressure. While, as Jason alluded to, work remains to be done to resource and implement the framework, it is a significant step in the right direction, and it inspires me to offer 3 ideas about how Canada can act to reduce the burden of chronic disease. My first suggestion is that we make chronic disease the organizing principle of the system, not an afterthought. The first lesson from both PHSSR and the diabetes framework is that resilient health systems are built by prioritizing chronic disease, not reacting to it. When we developed the framework for diabetes in Canada, it was in recognition of a simple reality. Diabetes was growing at an epidemic scale, touching nearly every part of the health system, yet there was no shared national direction for how we prevented it, detected it, managed it, or reduced inequities. PHSSR reinforces this insight across all non-communicable diseases. When responsibility is diffuse, outcomes are diffuse. When no one owns the full pathway, systems default to crisis response. When we treat only symptoms and only reactively rather than proactively, and from a whole person perspective, we sap the very possibility of a resilient healthcare system. So the opportunity for Canada now is to treat chronic disease, starting with high burden conditions like diabetes, as the backbone of health system planning for workforce, for data, for innovation, and for investment. That doesn't mean centralizing care. It means coordinating and aligning around improved health outcomes for the people whom our healthcare system is here to care. My second point is to build learning systems that allow us to act early, not just spend more. This second lesson is that resilience depends on visibility and learning. PHSSR is very clear. Without standardized, comparable, disease-based data, we can't see problems early, we can't measure equity, and we can't manage performance. This was one of the strongest through lines in the creation of the diabetes framework. Surveillance, data collection, and knowledge sharing weren't treated as technical details. They were treated as foundational systems capabilities. From a patient perspective, this matters deeply. Late diagnosis, fragmented care, and unequal access don't just happen because we lack compassion. They happen because systems don't learn quickly enough. That's why Breakthrough Type 1 Diabetes continues to fund registries of people with T1D in Canada, a critical first step in building resilient care for that community. Looking ahead, Canada has a real opportunity to move beyond data as a reporting exercise and toward data as an early warning and decision-making tool, one that tells us where prevention is failing, where access is breaking down, and where innovation is widening rather than narrowing inequities. That's how we shift from reactive care to anticipatory care. My third suggestion is that we pair national frameworks with delivery models that turn alignment into action. And this lesson is about execution. Frameworks matter. PHSSR makes that clear. The diabetes framework shows that Canada can align around chronic disease, but alignment alone doesn't deliver care, cures, or access. That is where delivery models come in, especially as therapies become more complex. In type 1 diabetes, we're entering a moment where curative cell-based therapies are moving from discovery to clinical trials. That transition stress tests the system in exactly the way PHSSR describes: trial infrastructure, workforce readiness, regulatory coordination, and speed of access. From the Breakthrough T1D perspective, initiatives like our proposed Breakthrough T1D Network for Canada are about meeting that moment by coordinating trials, reducing fragmentation, enabling knowledge translation, expanding access across regions, and helping to ensure that Canada is ready to deliver breakthrough therapies when they succeed. The important point is this: these delivery models should sit within national frameworks, not beside them. Frameworks set the destination, delivery models help us get there. So, in closing, if we put PHSSR and the framework for diabetes in Canada together, the path forward becomes clearer. Canada can build a more resilient health system if we organize around chronic disease as a core system priority, invest in learning systems that enable early, equitable action, and pair national alignment with practical delivery models that reduce fragmentation. From my perspective as a patient advocate and as someone working to accelerate cures, that's how we move from good intentions to real progress. And it's how we build a system that's not just resilient in theory, but resilient for the people who rely on it every day.
Mm. Kim, thanks so much for that. And now I'm going to pass the mic to our final respondent, Dr. Nakoshi Lamptey, who's the Deputy Chief Medical and Scientific Support, Population Health at Public Health Ontario. And Dr. Lamptey, before I turn to you, I'm just going to flag how appreciative we are, especially about your presence and participation. Occasionally, we have lots of conversations around the importance of system leadership without people who are system leaders present at the table. And knowing that you saw enough in this subject and this discussion to make time for it in your schedule, as somebody who thinks about this literally almost every moment of every day, is really meaningful to us, and we appreciate your presence. So we're excited to hear your remarks.
Well, it's my pleasure to be here. I'm delighted that I got the invitation, and a little bit intimidated to follow the excellent remarks that just preceded me. And I'd like to start by acknowledging that I'm speaking from the traditional territory of many nations in Toronto, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And it's now home to many diverse First Nations, Inuit, and Métis peoples. And it's covered by Treaty 13 with the Mississaugas of the Credit. And I'm saying that as an opening of a reflection of the fact that in Canada, we have a lot of wisdom that we can draw upon in terms of planning for a healthier future. So our traditional, the traditional lands of the peoples that I mentioned include a philosophy of reflecting on and planning for 7 generations into the future. So if we're talking about building a more resilient healthcare system and ultimately a more resilient population with higher levels of health, we should be drawing on that Canadian wisdom. When I read this report, it describes the need for fundamental reform. And it resonated so deeply with me because the goal of the work that I do in public health and preventive medicine is to help improve the overall health and well-being of the population and reduce avoidable gaps or differences in health as we try and raise the overall level of health. And so population health is not just the aggregation of thousands or millions of clinical interventions on individuals, but it's really the work of trying to change the conditions for living, working, and playing so that a healthier future becomes more likely and more real. So when the report opens with health systems worldwide need fundamental reform, shifting from reactive to preventive, from fragmented to integrated, and from volume-based to value-based, this is what I've devoted my whole professional career to try and facilitate. And I haven't done that alone. I see some of my colleagues on the call here. There are many thousands of health professionals working to create a healthier future. And I'm pleased to say that my lifetime has been long enough that I've been able to witness progress on things like Canada has the lowest rate of tobacco use among PHSSR countries. Age standardized deaths from air pollution have declined, and Canada ranks among the top 20 countries for increases in life expectancy. So if progress is possible, then do we as a country, do we want to tolerate decreases in disability adjusted life years, rises in multimorbidity, and non-chronic disease burdens that are disproportionately higher in, for example, Indigenous people? I'm going to posit to you that if progress is possible, then I don't think we want to tolerate those phenomena. So even from a personal values basis, if you haven't personally felt the human toll of these phenomena, either in yourself or in your family or in your circle of friends, we are all going to have to value this literally, as the impacts of these population trends consume a greater and greater share of healthcare treatment resources at a rate that is simply unsustainable. If we just look at our daily media reports, we see about the clear and present strains on our healthcare workforce, which is us, right? Those are our friends and family working every day to keep us healthy. And also in our community and acute care settings and provincial health budgets. So if it's not a moral value imperative, there is certainly a financial value imperative. That means we're not going to be able to treat ourselves out of crisis. There is urgency to act. And as the report notes, there is a window to act early through population level prevention. We can choose to meet this moment, and we can modify our muddling status on mortality from preventable and treatable causes with the kind of national vision, grit, and measurement that had us own the podium at the Vancouver Olympics, right? We did it then, we could do it now. So how do I know it's possible to improve overall health and address health inequities? Just as we've made tobacco consumption, acid rain, and COVID-19 deaths more rare, we have many strengths in our country to build, scale, and succeed. And much of the opportunities the report notes for optimization is coordination, such as convening to develop pan-Canadian standards for measuring chronic disease prevalence, multimorbidity, and associated behavioral risk factors. And provinces, as jurisdictions in Canada, have tremendous population power and the size and diversity of their residents. So if we can choose, collect, and analyze the relevant data, then the entry points for intervention are more promising. And this is where an agency like Public Health Ontario can provide some of that analytic momentum and innovation, such as some current and upcoming work with partners on modeling how much we can bend those multimorbidity curves or health impacts of particular chronic disease by varying different level interventions. And those interventions don't just have to be about pharmaceuticals or medical devices. They can be about choices we make in the environments to support health. As our previous speakers mentioned, we do have cancer registries, and they can provide a blueprint for how we can adapt the concept to other leading chronic disease conditions so that we can know how these system components collectively support or constrain earlier action on non-communicable diseases. Provinces also have the ability to put things on the agenda and borrow implementation successes from each other. As Dr. Field mentioned, innovation is not just about technology. Applying and scaling good ideas and practices that work is a way we get to better outcomes. For example, Public Health Ontario is working with Health Canada right now to understand the impact of wildfire smoke on populations and the relevant thresholds for issuing heat alerts. Just as we work on those pressing issues, we can similarly collaborate to develop pan-Canadian climate and health surveillance indicators and climate and health communications practices. The last piece I'll say is the report talks about the importance of focus on the social determinants of health. And this really requires connection. Wicked problems don't have a single solution. No single sector has the answer. But when we mobilize and come together, as we did in the COVID-19 pandemic, we've proven that we can actually improve overall health and reduce inequities. Because often the ideas that we get to reduce gaps in health outcomes actually benefit everyone. And so they are not either or, they're actually twin necessities for an overall better system and better health outcomes. So I'll just conclude by saying overall, I'm an optimist. I think you have to be to work in and imagine and help create a healthier future that's not yet here. And I'm hoping I can convey some of that sense of optimism to all the participants here to say we can be a leader. As the first country with the PHSR SR policy roadmap this year, let's go claim the prize of that healthier future for ourselves and generations.
Dr. Lanty, thank you for all of that, and thank you for that optimism. That's a lovely kind of place to end your remarks, but we'll hopefully hear from you again. I need to apologize for the fact that every time we have a conversation at RHC and we think we can do it in an hour with any degree of comprehensiveness and robustness, we're always unpleasantly surprised. So we will be bringing this discussion to a close around 1 o'clock, but it clearly is already telling me that we need to come back to this subject. We need to hopefully invite all of you back, both as attendees and as participants. And there's clearly many more things we need to unpack when it comes to this subject. So we'll only have a few more minutes of questions, but we will take all of your questions away, answer them as best we can, and make sure that we continue this discussion over the coming months. So thank you again for your interest and your engagement, everyone, both on the line and around this table. I'm going to try to see if I can ask each of you a question in the next sort of 10 minutes or so. So maybe we'll try to keep the follow-ons to a minimum and even the answers concisely, because if we could do 4, I think that'd be amazing. And then we'll have final closing remarks from Darren Phillips, who's the managing director of Philips Canada. So with that, Kim, I'm going to go to you first. It felt like if we were having this conversation 10 or 15 years ago, the sort of popularity, if you will, of disease-specific strategies or the kind of commonality of disease-specific strategies was much more common. It seems like we've sort of lapsed away from a willingness of policymakers to say, we're actually going to have a diabetes strategy, we're going to have a cancer strategy, we're going to have a lung health strategy, that we've moved away a bit from that. Any thoughts on how we sort of make a compelling and convincing case that we need to go back in that direction, as Sarah called for? And how do we make sure when we do that we don't end up sort of further fragmenting the sort of disconnects that Sarah actually called out in her report as well?
It's such an important point that you raised, Ross. When we started out to develop what became the National Framework for Diabetes in Canada, we were drawing actually heavily on an example from the 90-90-90 strategy developed for HIV/AIDS. And it really moved the needle for that patient population, partly because it was so focused and specific, as well as evidence informed and equity motivated and many other things. But one of the comments that we had for the government before the Framework for Diabetes existed is that without anything to guide us, we're just reacting, not planning for resilience. That said, we also don't want to end up in a situation where we wind up with a bunch of siloed and isolated strategies for specific diseases. One of the guiding principles for the National Framework for Diabetes is that it actually, as much as it's a framework for diabetes, was designed to help prevent or reduce the burden of many, many chronic diseases, cardiovascular disease, it's certain cancers, etc., because many of the things that we would do to reduce the burden of diabetes would have knock-on effects. I think that the key message I would have right now for our audience is that we can't lose what ground we've gained in terms of creating these broader frameworks that can guide and measure action. But we have to continue to remember that bringing these to life takes sustained resources and effort, and that it's about using data to report on our progress, to continue to learn from it, and find opportunities to broaden the impact of these strategies so that they're not working in isolation, so that we don't lose ground as we move forward.
Thanks, Kim. Dr. Lanty, let me come back to you if I can. So all the speakers talked about the importance of moving upstream, and that's a fantastic title of that report, Jason. But it feels like in the sort of competitive resource dynamic, arguing compellingly for more resources for prevention versus all of the other sort of worthy causes within the healthcare system can be really challenging. And I'm wondering if from your perspective, how can the broader group of voices that are around this table and frankly that are in attendance in this conversation, what do you need from those outside the system to be doing, to be saying, to be advocating for? How do we sort of empower people like you in the system to make the case in a more compelling and impactful fashion for more investment upstream, more investment in prevention? How do we make prevention more compelling, if I may say it that way?
Okay, I think you've given me a challenging question to try and address in just a few seconds.
Of course.
But maybe I will offer some initial high-level principles,
Please.
which is it's easier to be persuasive if there is a consistent single focus. So picking up on what Kimberly just said, if we as a sector working on various non-chronic disease conditions can have a common interest that we all advance, in addition to some of our more specific advances, if that call is heard over and over again, that helps register. And part of what makes something more compelling is if it's already consistent with a priority that's already been expressed. If you can talk about how your particular suggestion actually helps advance a priority that's already existing, helps make it more impactful, then it's easier to say yes, rather than it being a component of a new idea. We know that financial and cost effectiveness analyses are important. Those always need to be combined with the human stories. If you think about what gets on the agenda, it's often a very defined, visible, compelling human story that helps connect the dots into a clear picture, right? Because at the end of the day, at the population level, those dots are people.
Yeah.
So those would be my suggestions.
Amazing. Thank you for attempting to sort of distill some really important thoughts in a very short amount of time. Jason, maybe I'll come to you, and I think it's absolutely fascinating and important that Life Sciences Ontario sort of felt enough resonance in this subject that you produced your own report with some really important and complementary findings. And you started to talk a little bit about why it lines up really nicely with the mandate, mission, and priorities of a life sciences advocacy and community building organization to talk about chronic diseases. But I feel like that's such an important subject as to kind of why this and why now and its relationship to sort of the rest of the work you do, that I wanted to bring that question back to you, because I think there's some important stuff there that I want to let you even take it one more step.
Yeah, thanks, Ross. Yeah, this was something that when it was first brought to us, we took a close look at it, and I think it really resonated with us because we advocate, right from early stage research, right through commercialization, right through to products getting into the hands of patients. And it's important to recognize that whole ecosystem is codependent, right? If you take one element of that, the rest of it doesn't function correctly. So chronic disease, we really see this as an opportunity where innovators have an important role to play, and ensuring that patients are getting the type of innovations they need when they need them also drives things like access to clinical trials and investment decisions in the jurisdiction, in Ontario specifically, but you could say that for any jurisdiction in Canada. So, at a time when there is, all of this global geopolitical turmoil that we're living through collectively right now, and we're also collectively thinking about, how can Canada position itself to remain competitive. And Dr. Lamptey, I love your own the podium, comments as well. As we're thinking about that, we've got to be thinking about what are the things that are in our control? What are the things that we can do? And chronic disease, I think, as we've mentioned in the reports call out, the data is there. The impacts are real. This is a problem that is in our power to solve, and we can commit resources, and the frameworks are there for us to do. We just need to decide to do it and to prioritize it. And so that's why I think this ties together so well with all of the other work that we're doing.
Awesome. That's fantastic. Thanks for that elaboration, Jason. I think it's really important. Sarah, I'm going to come to you, and then we'll have some sort of final remarks from Darren Fisher. So, you've done over the last 5+ years a huge amount of work, culminating in the most recent report. An earlier report, this one, you've gathered incredible data. You've developed a number of kind of tangible, structured recommendations. It's really work to be proud of. So, as you think about sort of the next horizon of PHSSR in Canada, if there was sort of one or even two areas that you think has the greatest opportunity for the biggest impact, that's going to require elements of all of these voices that we brought here together today to focus on, what would you sort of charge us with? Where do you think are the areas of kind of maximum collective ability to move the needle that we might be able to kind of work on together across that next horizon?
It's a big question, Ross. I'm really pleased to have a chance to share the report and to have this great discussion. I think there's a few things now that I loved, Dr. Lamptey, when you commented on like tying what we're suggesting into current priorities, like what are people emphasizing right now? I think the topic of the day seems to be primary care reform, primary care improvement. This obviously aligns with much of what we're saying in terms of shifting care upstream, investing more in prevention and early diagnosis. This problem is going to take many years to solve. It's not going to be in a 12-month window. But if we align on something, whether it's, the investment in teams within primary care, improving attachment, but also, learning from examples where chronic disease management and care coordination around specific diseases is working. And so we have examples of innovation in Canada. There's also great innovations internationally. So we can learn from and try and scale these up and tie them to the current priorities of governments now. And we can have some meaningful action to improve the quality of life, improve our health span as we continue to, age, improve the quality of those years. And, that's just one area of focus that it's really hard to choose, but that's
Yeah,
what I'll end with.
that's a good one. Awesome. Thanks so much, Sarah. So, as Kim mentioned at the very beginning of her introductory remarks, PHSSR has been supported by a number of important, influential, and impactful organizations around the world. And one of those foundational partners for PHSSR is Philips. So now it's my great pleasure to introduce Darren Fisher, who's the managing director of Philips Canada, to offer some closing remarks and to reflect on what he's heard and where he thinks we need to go next. So, Darren, thank you.
Great, great. Thank you, Ross, and thank you for our panelists. And Dr. Allen, thank you for the very collaborative and insightful conversation today. As Ross just shared, my name is Darren Fisher, and I'm the Managing Director for Philips Canada. Philips is a global health company focused on improving people's lives through health and well-being through meaningful innovation, really innovation that supports patients, clinicians, and health systems. We continue to be proud sponsors and supporters of the PHSSR, and alongside other members, we share the commitment to strengthening Canada's health system. And so, as I said at the onset, thank you for a fantastic discussion and call to action. In particular, Dr. Allen, I wanted to extend a thank you for your leadership and dedication to this research. It's being released at a particularly pivotal moment, not only for the healthcare system, but also for public policy more broadly. And I view it as a potential to become essential reading for policymakers across the country and help to inform critical decisions on health system design, investment, and reform in the years ahead. I also want to thank Dr. Lamptey, Dr. Field, and Kim Hansen for leading such a thoughtful and grounded discussion. You highlighted with clarity and candor both the pressures facing our healthcare system and the solutions that are genuinely within reach. We appreciate the way the conversation was anchored in evidence, lived experience, and insight, while also inspiring practical opportunities and optimism for all of us to engage to drive system transformation. At Philips, we think about resilience aligned in very practical terms. That includes innovations that support access and earlier diagnosis, but it also includes the less visible foundations in the ecosystem that keep the healthcare system running. This point has been brought sharply into focus recently with global strain on helium supply. And while Canada is not yet feeling the impact, health authorities, group purchasing organizations are already developing mitigation strategies. So just quickly in that context, Philips introduced the world's first MRI system with a sealed helium-free operation, really reflecting our commitment to uninterrupted access to essential diagnostic care. And of course, supply chains are only one part of deep structural issues confronting the healthcare system in Canada. And today's discussion highlighted the persistent issues: data fragmentation, inequitable access, and system prioritization. And we recognize those challenges too, and we're working closely with healthcare leaders here in Canada and globally to address these challenges through earlier detection, expanded access to care, and more streamlined clinical workflows. So in closing, I would like to thank the PHSSR research team, the Resilient Healthcare Coalition, and Santis Health for their leadership and for providing a strong platform for this work. This kind of cross-organizational and cross-disciplinary collaboration is exactly what's needed to move Canada's healthcare system from reactive to proactive. And finally, to our audience, thank you to everybody who joined us today. I hope you'll leave with a clearer picture and understanding of the challenges ahead, and with a renewed confidence in what is possible when we align around shared goal of strengthening Canada's healthcare system for the future. Thank you, and I wish you the best rest of the day. Thank you.
Darren, that's perfect. Thank you all for being a part of this. Thank you all for your presentations, your engagement, your commitment, and we'll be in touch with all of you again very soon.